welcome to our presentation today, where we are looking at operationalization of event-driven PrEP from Eswatini. My name is Bongan Masango. So I'll be the one that will be chairing this meeting today. So maybe before we start, or maybe before we continue with the meeting, for those that may not be, because we have people that can or may not be understanding English, there's a button down there which talks about what? It talks about, there's a button here that talks about translation down there. So you can just go down there, click that button, and you select your language of choice. It's either you select English or you select Portuguese for those that understand Portuguese very well. We have our interpreters who are already on the line, ready to help us interpret. So you can again go into maybe our chat box, where people will be just saying who they are, where they are coming from. And then if you want to say something, you may raise your hand, and then we'll be there for you, or rather we'll be there to try and address whatsoever question that might be there. So ladies and gentlemen, welcome everyone. Maybe just to look at the presentation today, or rather where we're coming from. Eswatini, it's a country that has tried to achieve more on the HIV response. We have achieved the 95-95, as everyone can remember. But then again, as much as we have achieved the 95-95, we are still seeing new infections, and then this pushed us as a country to then now target more, or rather focus more on HIV prevention, and not just HIV prevention. We're focused more on what we call combination HIV prevention, and we have different interventions that we'll look at when we are talking about combination intervention. So those interventions include your voluntary medical male circumcision for those males that are eligible. We're talking condoms, we're talking your pre-exposure prophylaxis, which is PrEP. And then with that one, so today we'll be sharing, because we are one country that has started implementation of PrEP. We know PrEP is divided into the daily PrEP, and it's also divided. There's also your event-driven PrEP. So today we'll be taking you through the event-driven PrEP. On that one, our presentation will be looking at how did we come up with the guiding policies, guiding documents, how are we doing in terms of the service delivery, and then we'll also be talking about monitoring, and then we'll be sharing some successes, and then we'll allow the countries that are here for them to say if they have gained something, or rather what they are taking through in this presentation. Without a waste of time, we have Cindy on the line, Cindy Mata on the line, who's also coming from Eswatini, that is going to give us a presentation. I hope I'm not fast for those that do not maybe understand English. Maya, Cindy, over to you.
Thank you very much, Bongani, for the introduction and also for highlighting the content of our presentation. As introduced, I'm Cindy Mate. I work for the National AIDS Program. I'm coordinating PrEP in the country. So as a country, as he has already highlighted, we have scaled up PrEP. It has been some years now, and we have also operationalized the scale up of event-driven PrEP. So I will start by giving an overview of the PrEP implementation in the country. Next slide, please. Eswatini is, I hope we are all aware that we are in the southern part of Africa. We are landlocked between South Africa and Mozambique. And we have a total population of just over 1 million. As you can see, our numbers there. And our recent HIV prevalence for those that are age 15 years and above, we are currently at 24.8%, and we are one of those countries with the highest HIV prevalence, not only in Africa, but in the world. So we still grappling with that as a country. So next slide, please. As highlighted from the remarks that were made by Bongani, that is a country we've done well, or we have covered major ground in terms of the HIV response, where we've managed to achieve those UNAIDS global target of 95-95. And we've also managed to decrease our HIV incidence. We're coming from 1.13 in 2016, and we are currently in 2021, our HIV incidence rate is at 0.62. And that translates to about 4,000 new cases of HIV infection in a year, which to us it is concerning. We still need to reduce that. In 2016, our new HIV new infections were estimated at 7,000. So we've managed to cut down quite a number, which is significant, the 3,000. So currently, that's where we are standing at. And what is worrying is that our women, their HIV incidence remained very high, which is nearly estimated to be 7 times higher than when they're compared to male. We are standing at 1.11%, especially women in general, and our men are at 0.17. We are really concerned about that. Yes, when we compare them to the men, to the women, it is lower. However, it is still concerning with those numbers. We still need to do more to reduce it further. Next slide, please. So this is the roadmap that we have covered, or milestones that we have covered as a country ever since the 2015, when WHO recommended the use of PrEP as an additional HIV prevention in the HIV prevention package. That was 2015, and as a country, we started from there to start working on guiding documents that will help us to operationalize or to introduce PrEP as an addition to the prevention package that we have. We developed some documents, and at some point we launched some demonstration projects which covered the year 2017 up to 2018. That's where we analyzed the data that came from those demonstration projects, and the country made the decision to scale up PrEP. So it has been scaled up ever since 2019, the PrEP in the country, the oral PrEP. So in 2020, we all know that we were hit by the COVID pandemic, where we also looked at other models that we can introduce to make sure that PrEP is accessible to everyone. That's where we introduced the decentralized drug distribution. Due to that, people were limited to go into facilities. So PrEP in the country, as we were scaling it up, we introduced it in facilities. We used a phased approach, where we started in the demonstration project. We are targeting about 22 sites. That's where we learned about the operationalization of implementing PrEP in country. And then as we're scaling up, we're adding some facilities. The targeted facilities that were being added were those that are PEPFAR supported. And we're also targeting sites that are already providing ART. So we knew that already those nurses in those facilities, they are trained on IMI. They are also trained on nurse-led at initiation. So it was going to be easy because they already know about issues of ARVs, since we know that we're introducing an ARV-based intervention. So we targeted the phase-up approach, where we're adding the facilities, starting with those that are PEPFAR supported. And the reason we targeted the PEPFAR supported is because within the PEPFAR sites, already we have mentors, which include nurses and doctors. So our plan was to train them as trainers and then they were expected to cascade the trainings into the facilities which they are supporting, so that they continue to provide the post-training and mentorship. And then for those non-PEPFAR supported sites, they were in phase 3. Those included private sector, that is the private facilities. It also included those facilities that are public health facilities, which are not supported by PEPFAR because they are low volume, and also others are also faith-based facilities. So those ones, we were training them on site, like off-site. All the PEPFAR supported ones, it was an on-site training through the mentors. So ever since then, we've managed to scale up PrEP to all our ART sites, which are around 204 facilities. So currently, those are the facilities that are providing PrEP. As I've also mentioned, that PrEP in the scale up, it included implementation at community level, that is through mobile outreach, and we also introduced the decentralized drug distribution or commodity distribution during the COVID period. So that's how PrEP is being implemented in the country, facility, and also community. Next slide, please. As part of the journey, we know that by 2021, we as we were scaling up PrEP, the demand creation was largely happening within the facilities, and then we saw that it was a gap, and then we started thinking of developing an advocacy and behavior change communication strategy. So we're looking at different strategies of how we can improve their uptake. So that was in 2021, we started drafting a document that will guide us. And at the same time, in October 2021, WHO recommended the ED-PrEP to be introduced for male. At that time, it was recommended for targeting the MSM. So it was also then that, despite working on our communication strategy, we then started working on a job aid that was going to assist our healthcare workers in introducing the event-driven PrEP. The target was the MSM as per the recommendation by WHO then. So we developed this job aid to support, and we also come up with improve, edit, review our curriculum, training curriculum to also include the ED-PrEP. So we then, I think we started by targeting the 2 community centers which are targeting our KP. We trained those healthcare workers based on the curriculum that we've just reviewed. Information that we got, it was coming from WHO. We know that as they made the recommendation, they also provided information, and we also got information from other countries. Like I think it was Thailand, they already had some information on the implementation of ED-PrEP. So through FHI 360, we got such information, and we then worked on our own job aid and also some pamphlet that can support the facilities as they initiate. The MSM was a target at that time. So from there, I think it was, we introduced it around November, December. We trained those facilities, the MSM or KP community centers targeting the MSM with the job aid and also the pamphlets that can be shared with them, with the client when they're initiated. We then also got the recommendation from WHO that it can be also include other men, those that are assigned male at birth. So I think that would be our next step, where we then include event-driven PrEP, not only for MSN, but then for the general population. So we may, please, next slide, move to the next slide. So in 2022, we also introduced our opt-out approach for pregnant and breastfeeding women, since this is part of our priority population, and we have seen that as part of PMTCT, we just integrated the PrEP to be part of that package so that they are being offered. So the communication strategy was finalized and launched in 2022. And we know that WHO recently in 2023, they've recommended the use of the HIV self-test for initiation and also for follow-up on PrEP. So we also introduced that. It is included in our PrEP guideline and also in our HIV, the National HIV Management Guideline. And we are also working on demedicalizing PrEP. So the way we are planning to do it, it will still be provided in facilities, but we are now introducing the HTS counselors to be the ones that are doing the referrals. The nurses can prescribe, the plan is that the nurses can prescribe the PrEP for 6 months, but then in between for the follow-ups, they can be tested with the HIV self-test assisted, and then they can refill within the HTS department rather than to still queue to be seen by the nurses or the doctors for those refills. And we are also looking at introducing the refills in private sector, which is the pharmacies. It's mainly targeting the pharmacies because facilities are already providing it. Next slide, please. So in this slide is just for us to appreciate how we are implementing PrEP in country. As I've already mentioned, that we are implementing in facilities and also at community level through the DSD models, which include our outreach, the decentralized drug distribution. And we are having our nurses who are trained on EMI, that's a requisition, where they're trained on EMI and also trained on PrEP. So they're the ones who are initiating our clients on PrEP, also our doctors. Anyone that is trained on PrEP from these others, they are able to initiate clients on PrEP. It also includes our nursing assistants. They are responsible for the referrals. So for initiation, it is the nurses, the state registered nurses. And oral PrEP, we have tried to integrate it in all entry points, especially in the primary facilities. Where we are struggling to integrate it in all entry points is the big hospitals. So in big hospitals, it is in the outside because they are within the hospital and also in the OPD. But for these primary, the clinics, those are the facilities that we call our primary. It's clinics plus public health units. We are providing it in all entry points. And then in terms of our consent form, consent age for to be initiated on PrEP, our age is 16 years. However, we are also providing to those that are 16 years and below. We categorize them as mature minors because they are 16 years, they are below 16 years. However, it's because they are presenting with STIs, because they're sexually active. They might be pregnant, they might be lactating, they might be requesting it because they are sexually active. So we are also providing PrEP amongst those that are below 16 years and without any parental consent. And for the ED-PrEP, as I've already highlighted, that we introduced it, we started with the MSM and then later on we included our men in general. So ever since then, when WHO recommended it in 2022, what we have done, we have included the ED-PrEP in our integrated HIV management guidelines, which include all the components on the HIV management, not only prevention. And we also have our specific PrEP guideline, which is currently as a guide. We are waiting information on the KEBLA since we've already included it in anticipation that we'll be also introducing KEBLA or cabotegravir, the injectable, PrEP injectable, in the near future. So we've already included that. So that's why our guidelines are still a draft. We are waiting a training that will be happening in Zambia in the next weeks. So with the information that we're going to get, we are going to finalize this guideline. Otherwise, ED-PrEP is already there. Next slide, please. So these are the key and priority populations for PrEP. The way we have picked this population group is based on the incidence rate that came from our FIA, and where we didn't have incidence rate, especially amongst the the key population, the sex workers, the MSM, the transgender, the people who inject drugs, we have used their prevalence and also our recency data. So these are our population that we are targeting for PrEP. Initially, we didn't have the high risk females, and we had high risk we didn't have the high risk females, which I've highlighted, and also the people with multiple sexual partners. So in the new guidelines, these are new priority populations that we have identified, and this is based on the incidence rate that we've seen from our FIA that we conducted in 2021. Next slide. So in addition, it's not only this population that can benefit from being initiated on PrEP, it also include anyone who may perceive themselves to be at risk or who may be coming to the facility and requesting PrEP, because we take it that they are requesting PrEP or they are perceiving themselves because they know they are at risk. So anyone beyond this population or priority populations, they can still access PrEP in the country. Next slide, please. So this is our criteria for PrEP use, where irrespective of the rescheduling. So you have to be HIV negative. You have to be no suspicion of acute HIV infection. You are not indicated for ED-PrEP. So we have an assessment or eligibility criteria that we are using, which include a whole list of the suspected acute HIV infection, and also we have a question that refers to any exposure in the previous 14 days. And then for the signs and symptoms, we are using in the past 3 days. So we have that list of flu-like symptoms that we usually ask the clients about, but we refer them to the past 3 days, and then for the exposure in the past 14 days. So that helps us to pick people that might be in the seroconversion phase because of the acute HIV signs and symptoms, or they've exposed themselves. They will benefit more on PEP because of an exposure that has happened in the past 72 hours. Also, those that are requesting PrEP or there is substantial likelihood for acquisition of HIV, we are assessing them. We have an assessment tool that is embedded in the HTS. So once you test negative, we establish if you are sexually active, and if you are sexually active, then there is other list of questions that we ask to see if you are exposed. Then you should be willing because of the follow-up appointments. Also, you must be free from any contradictions for oral PrEP. We know we usually link it to the TF. And then I've already mentioned that we are using 16 years as the consenting age for PrEP. Unless you are a mature minor, you still access PrEP. Next slide, please. So for the oral PrEP, which we are currently providing, we have these 2 different dosing schedules. That is the daily oral PrEP, which I can say it's largely targeting our females. And then if you are male, we are using the event-driven PrEP, which is also known as the 2+1+1. So these are the 2 scheduling that we're using as a country. Next slide, please. So we'll go into the event-driven PrEP. Please continue to click here. So for our event-driven PrEP, please continue. So this is how we have defined the event-driven PrEP that is provided to anyone that is negative, who have been assigned male at birth and not exposed to the exogenous hormones such as the gender-affirming hormone therapy. So that's how we have defined the event-driven PrEP as per the definition from WHO. And in terms of the priority populations, which I've mentioned earlier on, please continue to click. Which I've mentioned earlier on, the target as per the definition up here is for the cisgender men. It can benefit the transgender women and those that are non-binary individuals that are assigned male at birth and they are not taking any gender affirming hormones. So from the key and priority population, these are the population that are benefiting from the event-driven PrEP. It will be males that are coming from a serodifferent couple, those MSM, the high-risk males that we have highlighted earlier on, the transgender women, and also any clients that will be presenting with STI who are males at the facility or at community level or any PrEP site. So these are our priority population for the event-driven PrEP based on the definition that we have up there. Next slide, please. And then in how are we selecting the daily and the event-driven PrEP? I think in my previous slide, I've already mentioned that for our females, we initiate them when they're interested in taking PrEP. We initiate them on the daily PrEP, where they're expected to take the PrEP daily for the 7 days before they expose themselves. And then anyone that is assigned male at birth, amongst that group that I've already highlighted in the previous slides, they are started on event-driven PrEP. So the choice for them to maybe select with time for the males to select being on event on the daily oral PrEP, because all of them, the males, those that are assigned male at birth, they are started as event-driven PrEP. And then if they are going to be, with time, they're going to be taking the PrEP as daily, that one, we also give them information. It depends on their situation, because they might start as an event, a single event, but then they might find themselves that they are frequently exposed, which might necessitate that they take it daily. So it depends on the individual situation, on their frequency, on the exposure, predictability, which an individual has sex, as well as their preferences. So ED-PrEP may be more appropriate to those that may find more effective and convenient, have infrequent sex, because you also need to be to plan ahead. When we engage the healthcare workers, we also highlight that it might be those people that may have less than 2 times per week or on average, and are able to plan for sex. At least they must have 2 hours in advance, or delay the sex at least for 2 hours before that exposure. A client may also wish to transition between the daily and event-driven PrEP. That is according to their circumstances. I think it's what I've already highlighted, that a client may be initiated on event-driven PrEP, but later on, due to their circumstances, they may find themselves that they're having frequent sex, and they can take the PrEP as daily until that exposure is stopped. Please just click. So this is a note for the providers, which is speaking to PrEP providers and potential ED-PrEP users should determine together whether the daily PrEP or the event-driven PrEP may be most appropriate by discussing the frequency and the predictability of the sex and asking about dosing preferences. So it is very important to engage so that the clients, whenever the situation changes, they will know what to do and how to continue taking the PrEP. So this is the information that we always emphasize to our healthcare workers, that as they engage, may they emphasize, because maybe on that day, the client comes for PrEP, they might be thinking of a once-off event, but then with time, they will find themselves that the exposure is so frequent, so they must know what to do, because the healthcare worker might not be there. So it is important to engage and clarify in case such situation happens. Next slide, please. So this is one scenario, dosing scenario, where we are seeing that this client is coming and in his mind or in his plan, it's a once-off event, where according to the WHO guidance, you take the 2 loading doses at whatever time that you pick. At least you must have 2 hours before. It's 2 to 24 hours before. And then the next day, around the same time, you take another drug after the exposure. So that happy phase there, it is the time for exposure. So it has to be 2 hours before the time for that exposure, which is that's the time that is there, that is the 11 p.m. And then the next day, you're supposed to be taking the one drug at the same time as you took the other one. And then the third day is the same story, that you take the last one. So it's 2 drugs after the exposure. So let's go to another scenario, which we always engage our clients on so that they understand. So in this one scenario, it's a multiple consecutive days where the sex happened for days. So you take your loading dose. As long as you continue to expose yourself, you continue taking 1 pill per day around the same time. And once the exposure, the last day of the exposure, then you will continue to take the 2 again to close up on that exposure for those 3 days. So this is another scenario which we also highlight to our clients. Another scenario, the next, yes. So this one is multiple non-consecutive days where you're loading, you have sex 2 hours to 24 hours before, and then there is no sex that happens in between. You continue to take your drug, and unfortunately on the 3rd day, when you are supposed to take your last drug, closing up on that first event that you have planned, sex happened. So that means that individual will continue taking the drug on that day at the same time. However, it's not the closing dose. It means that that's a dose for the day because they've exposed themselves, and then they will take the 2 other drugs just to close up on the exposure that happened on the 3rd day. So this is a non-consecutive days. So it's another scenario that we also train our healthcare workers on, and also our clients, so that whenever they have the situation, they'll know how to handle it. And it's also in the pamphlet that I've indicated earlier on. So this one is showing a switching between the ED-PrEP and the daily PrEP. So I've already highlighted that it will depend on the client situation. They might be thinking of an event, and then they find themselves that they are having sex in consecutive days. That means that they will just take the loading dose and continue taking 1 drug as long as they're exposing themselves. And then at the end, once the exposure is stopped, then they will take those two last drugs, 1 each day. So there are many situations that may change the situation for people who are, please just continue thinking. That may change the situation for people to find themselves between event and also daily. So this is one situation where there was an event and there was no sex happening. And then at some point, sex was happening every day. So the client was taking the drug every day. Another scenario you can click. So another scenario, you may start as daily, and then you find yourself that there is no sex, and there's just, after some time, there's just 1 event. Also, you can move from daily to event. So what is a takeaway here is that a client can come at the facility with the exposure that will be daily. We start them as event, because what is important for the male clients is the 2 drugs, the 2 loading drugs that you take 2 to 24 hours, and you continue taking the 1 in between where you are exposed, and also closing with those 2 separate pills at the end. So whether it's a once-off, whether it's a daily, the way males are taking it, it's similar to how we are using the event-driven PrEP. So next slide, please. So this is how we are prescribing the oral PrEP. So for everyone, whether you are taking it as daily, you are a female, you are taking it as event, you are male, we are for the first initiation, we prescribe 1 bottle for everyone. And even our visits, they follow the same visit that we've been using for the daily, which is when we initiate you, we expect you to come back for visit 1 at 1 month. And then after that, we then expect you to be coming every 3 months. So we are using the same scheduling for the event-driven PrEP for daily, and also for the event-driven PrEP. We are not counting drugs, even if the client is saying it's just a once-off event. we are not providing maybe the 4 drugs that we are expecting the client to use. We still provide the whole bottle. The reason we're doing that is because the situation may change and the client must have adequate drugs to cover that period. Should they need to use the drugs every day, it's no longer a once-off event. So they must have adequate drugs. So I will highlight at the end what are the challenges with the challenges that we have seen as we are implementing the event-driven PrEP. So this is how we are. It's similar for everyone the way we are prescribing. It's 1 at initiation, and then we expect them to come at month 1. At month 1, what the activities that we usually conduct there, it includes counseling on effective use, addressing any side effect. We know PrEP, it comes with side effects that usually clear up in 2 to 3 weeks per, and depending on individuals. And also we are making sure we are ruling out any acute HIV infections, which we have seen that our healthcare workers at times they miss acute HIV infection, and then we pick the infections because at that time when they come at month 1, our clients are seroconverting. So it is very crucial that we still emphasize that our clients, by all means, if they can come for the testing at 1 month, and then we'll then schedule them for that a second visit, which will be the 3 months. So next slide, please. So on the event-driven PrEP prescription and the refills, our clients, as I've already highlighted, that the reason we're giving that whole bottle, even if they are saying they're going to use it once, it's a once-off event, is to make sure that they are cushioned in case they will have more exposures. And also we know they will have challenges in going to the facility frequently. So it will take care of whatever other exposures that may happen. So for the event-driven PrEP, when they come after that first visit, let's say we have provided those the 3 bottles for the next 3 months. Whenever they come, we always ask them how many bottles do they have, and then we'll subtract those. In case where we have given them maybe the 3 bottles, and then when they come, we find out they still have 2 more. There is no need for us to still supply the 3 more bottles. We rather close up on that 1 and just provide 1 to make sure that they always have them, because that will tell us how much that client is using those drugs, rather than to give them more drugs, yet the way even they are using the ones that they have, it's very slow. So how we are determining how many we are giving, it's based on the usage from the previous. So clients using ED-PrEP is provided with 2 HIV self-tests and encouraged to use the test prior to new period of exposure. This is what we have included in the new guideline. The reason we are now distributing the HIV self-test is because our clients who are initiated on ED-PrEP, they are not coming back for those follow-up visits. So we've decided to distribute the self-test so that whenever, if they've exposed themselves, rather than to continue taking the drug, which maybe they might have contracted the HIV, at least if they can conduct the HIV self-test before they use the drugs for another exposure, at least that the test will sensitize them just in case it becomes positive for them to come to the facilities, because this is the challenge that we're faced with. They are not coming back, yet we know that they still have the drugs. As we've done the call at the beginning, we know that the reason they're not coming back is because they still have drugs, and we know that they're continuing to use the drug. So we're trying to reduce a situation where we'll find ourselves with a lot of seroconversion, which may lead to HIV-DR, because they would have continued to use the 2 drugs, yet they're already infected. So this is a way of also cutting down on those challenges that we might face in the future. However, we haven't seen much of seroconversion coming from the males who have been initiated on ED-PrEP, but we are taking precaution by supplying these HIV self-tests so that they can be conducting the self-test as they continue taking the drug at home. Next slide, please. So this is how the follow-up, I think it just summarizes what I've already alluded to, that we have initiation and we have a 1 month visit after initiation, and then thereafter they come every 3 months. We have tried to also align the follow-up visit or the subsequent visit with any other services that they might be coming for. So it's not only this, or does not only affect our male clients, it's also something that we are considering for even our female. We align with FP, with ANC, with PNC visits so that we try and reduce the frequent visit to the facilities. So that's what we have done. So it's outside the event-driven PrEP. For everyone, we look at other services that they might be coming for, which it's in their plan. So next slide, please. So the follow-up appointments, a client should be willing and able to come. I think I've highlighted this, and please continue clicking. So why is it important? I think I've also highlighted continue clicking for this follow-up. So this is the information that we usually assess as they come for their follow-up visits. As I've already highlighted the issue of the acute HIV infection, also to verify the HIV status as we do the testing, and also to reduce likelihood of drug resistance, as I've already highlighted that we want to pick them as early and avoid them to continue taking the drug yet maybe they're already infected, and also to manage the side effects, as we know that some they wish to continue taking PrEP, but because of the side effect, then they stop, yet the exposure is still there. And also to address any concerns that the client may have. So these are the reasons why we always emphasize on the follow-up visits, their importance. Next slide, please. So for the data collection tools, we have two systems in the country. Our data collection tools that are embedded in our client management information system, and in very few facilities, because we are continuing to rolling out the client management information system, the electronic version in all the facilities. We still have few where we're using the paper-based. There's a register, and also there's a PrEP monthly summary form. And then for all our service delivery points, we have what you call a PrEP client appointment card, where we record the next appointment date for them and any comments may wish to include there. So within the electronic CMIS, we have a PrEP a module which is capturing all the activities, which include the PrEP initiation, the follow-up visit, the side effects. The healthcare workers can include them there. Even the event-driven PrEP, it has been part of it. There is a tab where we are able to capture it. So whenever a male is being initiated, we are able to pick them under the event-driven PrEP, and also the daily for all our females. And then the PrEP register, since I've said that we are rolling out the electronic CMIS, so we are no longer printing the PrEP registers. However, those facilities that are still using the PrEP registers, they are just including it under them. There is a tab which is talking to type of initiation. There is new, there is restart, there is also a restart after 12 months. So that's where they're indicating the event-driven PrEP. And we have a summary form, which they also provide the information on almost the indicators that we are tracking and reporting at regional and national level. I've already highlighted on the appointment card today its importance. Next slide. So this is just our appointment card, how it looks like. It has the facility name, the client ID, and also it has the visit date and any comments or notes that the healthcare worker may wish to put, and then the next visit. Next slide, please. So this is the how the register looks like for those that are using the register. I've already highlighted that within the register, we have where we had initiation type. We are recording whenever we are initiating a client that is a new initiation. It's a restart. It's a restart after 12 months. It's a transfer in, a transfer out. So for the ED-PrEP, that's where they're highlighting. Yet in the electronic version, it's already there and you just click. So this is what they are doing with the paper-based. And we're able to check how many are initiated on the event-driven PrEP. Please, next slide. So for the demand creation, we have used different strategies, including the radio adverts, social media, outdoor placement, which include billboards and also IC material. So this is part of the IC material that we've developed to try and create demand for the event-driven PrEP. Next slide, please. Next slide. So for our uptake, this is a slide that came from data that coming from the KP centers, where I have this arrow here. It's where we started introducing the event-driven PrEP for the MSM, and you can see ever since then we had an increase of the uptake among the MSM on the event-driven PrEP. So ever since then, it has improved compared to the years where we're just providing the daily oral PrEP. So this is for us to appreciate that, yes, there is some significant increase in terms of the uptake with the event-driven PrEP amongst our males. Next slide, please. So this one is coming from our public facilities. This is a cascade that we're using as a country for tracking our PrEP. It's not only event-driven PrEP, even for PrEP in general. This is a cascade that we're using where we're looking at all those that are testing negative. We are conducting the risk assessment to establish how many people out of those that are negative, how many are at risk. And out of those, we then also do the eligibility criteria for PrEP. And most of the time, we find that majority they are eligible. And we are also tracking the offering. Since within the STS, we are offering the whole package, is not only PrEP. And we also indicate for PrEP, we do indicate how many were offered for PrEP as part of that package. So you'll find that most of the people for the offering, it will depend on the facilities. We are tracking how many are being offered the PrEP as part of that package. So you can see here that our data is showing that almost 60% are being offered and only about over 6,000 are accepting PrEP as is being offered. And then at the end, we can see that for men, once they've accepted it, they are likely to be initiated on PrEP. So our initiation, as I've highlighted earlier on, it is happening in all the entry points. So they are accepting, the acceptance is being established from the STS department, and then they are linked to the nurse, and then the nurse will initiate. In some facilities, the nurse will come to the STS department to initiate. So it depends on the facility. It's either they're being referred to a consultation where the nurse is, or where the client is supposed to be accessing the service that they are coming for if it was not the PrEP. So they will be initiated there. At times, the nurse will move to the STS department to avoid the referring or the linking of the client to different departments. So that one is facility-based. Next slide, please. So this is just the trends of ever since we started. So as I've indicated earlier on, that we started training our public facilities around March. So by April, it was February, March, we're doing the trainings of those mentors. So by April, the implementation was happening in facility. That's where we started appreciating the increase in the number of men that were initiated on PrEP up to now. This is the last one. It's our current quarter, the April to June 2023. So it has been increasing compared to before when we were providing it as daily PrEP. Next slide, please. So we go to our challenges and also the lessons. I think I've already highlighted that today is they are very slow in coming back for follow-ups, and where we have made calls, we have been able to get our clients. They've reported that they still have drugs and they're using it as per an exposure. So yes, it is affecting the continuation use. We are not able to track that, yet we know that for PrEP, for it to be effective and for us to see the impact at the end, we really need to be tracking the continuation use. So it is a challenge when we want to track the continuation use. Clients are switching between the daily and ED-PrEP and do not follow how they should be taking the drugs. Hence, what I've indicated earlier on, that we are emphasizing to healthcare workers that they emphasize on the possibility that in future, depending on the situation, they might be moving from event to daily. So it is important that they are well educated and also provided with a pamphlet which had all those scenarios that I've presented here, so that they can understand in case the situation changes from being an event to a daily exposure. Clients do not follow religiously the time given for taking the PrEP. We know that for you to take the PrEP, it's supposed to be the 2 hours at least to the 24 hours. So that emphasis is still made by our healthcare workers. It's something that we have seen that at times they may not have the 2 hours at hand before the exposure, which might be a challenge. So we are trying to send out messages at facility level during the health education service sessions, and also the engagement, and also those pamphlets that are emphasizing on the importance of the 2 hours before, and also how to take it when you are closing up on that exposure. Clients not coming back for follow-up visits, I think this is the very same, and the challenge is the follow-up test, which we are just afraid that what if they've seroconverted and they are continuing to take the drug. And there was a lot of confusion, especially when we introduced it for only the MSM. Other men were starting to ask why are they also not benefiting from ED-PrEP, and then there was that a communication from WHO that it can be provided to anyone who's assigned male at birth. So that's when we started to open it up for every man. Next slide, please. So what have we learned from ever since we started the implementation? It provides eligible users with additional option for taking oral PrEP. We know our clients, they've been complaining about PrEP, that it's really, there is the issue of the pill burden of taking the drug daily. So with the event-driven PrEP, it has reduced that and it improves the uptake, because some people, they were really worried to be taking the drug when they know it will be a while maybe before they are exposed. So, and even to take the drug the 7 days before you expose yourself, it was also another challenge. So we have seen that from even the feedback from them, it reduces that, and it has improved the uptake for those that it was a barrier to be taking those drugs for 7 days before the exposure. The calling of clients is due to for refills. We are doing that. We have our appointment register, which we've been using for ART. We are also including the PrEP clients, especially those that have indicated that they need a long-term use of PrEP. So we include them there so that we can call them when they are due for their appointments or refills. So that one, it is sort of really helping to also understand what is happening. However, we know it's a costly strategy. However, we are doing it because we've been doing it for the ART clients. So there is also a need to strengthen the PrEP screening and ensure initiation of clients who are determined to take PrEP and will come for appointments. Otherwise, some are linked to other HIV prevention strategies. So If there are issues, it is also important that we engage them so that they can pick what will work for them. And conducting the community refills through the centralized commodity distribution, it also improves the continuity. As our clients, there are issues with the traveling to the facilities, the frequent travelings for these refills. So bringing the service to them, it has also improved their continuation use as it cuts on the cost for transport going to the facility. So those are the things that we've learned as we're providing the ED-PrEP or PrEP in general. I think this should be my last slide. Yeah, with that, thank you so much for listening.
Wow, thank you so much, Cindy, for the nice and detailed presentation about how Eswatini has managed to implement and then improve, or rather increase the uptake of PrEP, especially ED-PrEP. Ladies and gentlemen, maybe we can open questions now. We can start our discussions. And Cindy, we have some questions that have already been asked. Maybe if you can go to the chat, you can answer some of the questions while we are having a discussion. There are questions that are there where they are talking about how do we do the education around ED-PrEP clients on when to switch to daily PrEP. And then we also have another question that looks at since the start of ED-PrEP services, how has demand changed? And have you ever had seroconversion from ED-PrEP? So maybe we can answer those one while we're still waiting for people to raise their hand and ask questions.
Okay, thank you. I'm trying to look at the questions here.
Okay, the first one was talking about how are we as a country educating ED-PrEP clients on when to switch to daily PrEP should there be need?
Okay, let me respond to that one. Yes, okay. We are engaging them as we initiate them. We usually present all the scenarios because we may not know what will be their situation be like, and also as the client, they may not even know their situation also, because that will depend. For some of them, it will depend on. They may not predict predict sex. It will depend on the partner. So most of the time, it's better to give them all the information that if it's a once-off event, this is how you take the PrEP. In case it happens that maybe you have it today, you're trying to close up, it happens before you finish, it's the second scenario where you have a non-consecutive days. And then in case there are consecutive days where you are exposed, this is how you are taking it. That is more of the daily PrEP. Most of the times what we have seen, they don't know what will happen. For them, they will come looking for an event-driven, and they find themselves that it may happen frequently. So you have to cover all the scenarios. And what has helped them, from the feedback that they're giving us, it's the pamphlet that we have printed, which we usually distribute as we initiate them. That helps them to use those different scenarios depending on their own scenarios that they will encounter. So yeah, we have to make sure that there is that to remind them, because they may forget to be telling them of all the scenarios that might happen. At least the pamphlet helps them to know how to handle the situation at that time.
Okay.
Another
okay,
one.
Thank you so much, Mages. And there's a hand from Maleboho. Can you go ahead and answer your ask your question?
Okay. Good afternoon, and let me first appreciate the comprehensive presentation from the Eswatini team. And apologies, I joined a bit late. I may have missed the part that I would want to ask about. However, I'm interested on the issue of demand creation strategies, or even public education activities that the team embarked on to ensure that they improve on PrEP uptake? And then the second question that I would like to pose is that of gender-based violence, especially amongst PrEP users. Like the screening part of it, how is the incidence of gender-based violence amongst the same group? Thank you.
Thank you so much. Thank you so much, Malebo. Maybe, Cindy, before we take that one, can you go to Daniel so that you combine both questions, the one for Malebo and then the other one for Daniel. Daniel, you can go ahead. And then maybe before you, Daniel, I think we have a team here, a Eswatini team. I saw that there is Kazani here. So maybe you can help Margaret Cindy Kazani to answer the questions that are on our chat. You can go ahead, Daniel.
Hi, good afternoon, and congratulations for the team of this presentation. And cool, HIV program is progressing very well. As that on the 95 only 3 engaged free, because I could understand that. Yeah, and we are almost have the same steps here in Mozambique on the initiation of the program of PrEP. Almost the same. And I could see that we face almost the same challenges, and we are on. I could see that you are offering all the doors in the health facilities, and I don't know if it was my understanding that you are offering even the inpatients, the people that are inpatient in the hospitals, but the inpatients, okay. And that's something that I would like to understand, because we are using other modalities. The other dose. And we are using some of the doors at the health facilities, and the other doors are creating the demand. But you are covering all the doors, initiating the prophylaxis.
Dr. Bongani, perhaps we can move ahead.
I would
think
like
Daniel
to understand.
is struggling with his audio at the moment.
Okay, maybe we can go ahead and allow Cindy to answer some of the questions. I don't know whether you got what Daniel was saying, my Cindy.
This meeting is being
Daniel,
recorded.
I tried to listen. I don't know if the breaking was happening on my side or it's happening on his side, but I did not get his question. I only heard about maybe wanted to find out if we were providing PrEP to inpatient. If that is the question, I've said in the hospital we are providing PrEP in the OPD, and we are also providing in the ART side. The reason we are providing in the ART side is because we are seeing clients that are in the serodifferent or serodiscordant relationship who are coming together. So the negative are the ones that are accessing the PrEP there. Otherwise, if they're coming for any other ailments in the OPD, they do access a PrEP there. Then the first question, it was about the demand creation. How are we doing it? For demand creation, as I've highlighted, that we have developed the advocacy and behavior change communication strategy, which has some targeted messages and strategies and platforms for accessing the different priority population that I've highlighted here for PrEP. So we're using those messages which we have packaged them, and we are implementing it based on the recommended platforms which came from the engagement of the different priority population when we were developing the communication strategy. So it includes IEC material distribution, which is in a form of flyers, brochures, posters, which is usually distributed through the facilities. And we are also distributing through the peer education program, targeting the different priority population, that is your key population, your adolescent girls and young women. We also have organizations that are working with men, where they are also distributing the same. So it will depend on the target population when they are being engaged, and also when they are engaged in facilities, whether they're initiated or they are interested, they need more information, they will be provided with the brochures or the flyers. Otherwise, within the facility, in the community, we have these the posters. And then we also doing mass media, which include use of our radio. We've used our TV, where we are also conveying the different messages for the different population group, which also includes the men with the event-driven PrEP, and we've seen that working a lot. And then within facility, there are group sessions, there are health education sessions that are happening. We also have some short videos that we are also using, or audios that we are playing on TVs which are in the facility at the reception. So those are the strategies that we have used. And in terms of the GBV screening, we do have a screening tool that is embedded in our HTS, where we are also screening as we screen them for different issues, which include the GBV, their exposures, also STI. So that screening tool is comprehensive to pick up on these issues, and then they will be, as they access the service, whatever issue that have been picked from the screening tool, then it can be dealt with. Yes, for GBV, we do have cases, but they are not really linked to the client taking a PrEP. You may find that they are linked to other things. We know that PrEP is not discrete. That's the reason why we are looking at providing the option, expanding the option, the PrEP products, so that some people, they do have issues. Some of the reason why people are not taking the oral PrEP is because it is difficult for it to be discrete. Even with I think the adolescent girls are also struggling. So we are also looking at expanding the options so that people can choose, especially the women can choose PrEP products that will be discrete to address the issues where for them to use that type of prevention method, they need an engagement and approval of the spouse or the partner. So those are issues that are also, we've picked them within PrEP. So as a country, we're working on expanding the option. We've already started piloting the ring, and we, with the support from PEPFAR, will be introducing the Kevlar or the PrEP injection by next year. So we believe that is going to close up on these pockets where we have seen that people are really struggling because of the gender imbalance, power imbalance that is happening within relationships. Yes, it is an issue that I think we are all faced with.
Okay, thank you so much, Cindy. There's Pearl. I don't know. There was also Ngulu, but he or she decided to drop the hand. So Pearl, can you go ahead?
Thank you and good day. Thank you, Eswatini, for your presentation. I hope you can hear me from your side. My first question is around the monitoring of HIV self-test in PrEP clients. You have mentioned that you use the HIV self-test in clients who come for the refill at 3 months, and you also provide ED clients, PrEP clients with HIV self-test.
It looks like
because
Pearl is also having some sound issues, Dr. Bongani. Daniel
Sorry, you can't
seems
hear
to
me?
be back, so maybe we can go back to Daniel.
No, Pearl is clear.
Can I continue?
It's okay.
Yeah,
It's okay. Yeah.
Pearl is clear.
Apologies,
Okay.
apologies. I
The-
couldn't
the-
hear
the
Pearl on
other-
my side. Sorry about that.
Okay. The other scenario you gave where you give HIV self-test to ED PrEP clients because you have a challenge where they are failing to come back for the HIV test. So you end up distributing self-tests to them to use the self-test every time before the next exposure. So my question is, how do you monitor the self-test and do you manage to get the results from them? And then the other question, I don't know if you have already answered it, is around the seroconversion. What have you experienced around the seroconversion ever since the introduction of ED-PrEP? And then lastly, I also wanted to know if there has been any improvement in demand or uptake of PrEP ever since you introduced ED-PrEP and also introducing PrEP in private sectors. Thank you.
Okay, thank you so much, Pearl. Margaret, can you go ahead with that one?
Okay, thank you so much, Pearl, for those questions. So in terms of the monitoring, with the use of the HIV self-test. Okay, HIV self-test for the initiation and follow-up, that one is linked to, it's happening at facility. We are doing the assisted HIV self-test. Since the recommendation by WHO that we can now use it for both. So it's done at facility level by the HTS instead of using the traditional or the national algorithm of the RDTs. So for the one that is being distributed, as I've highlighted, it is trying to close up on the gap that let us give them the self-test so that before they use the drug, in case they've exposed themselves in between, at least for them to test. Because if someone is doing the self-test and maybe the test will be positive because they would have been given the information when the self-tests are provided, then they will know that query might be positive. I shouldn't be taking the drugs because that's the information that is being given, that as you do conduct the self-test, in case it becomes positive, that might be a query, I might be positive. You shouldn't be taking the drug. Rather, go to a facility and confirm. So we know people, it's more of sensitizing them. However, if we were to say it's easy to monitor, no, it is meant to sensitize them not to continue taking the drug in case that's a true positive and they might be taking the drug yet they're already positive. And by the time we discover or we identify them to be positive, taking that two drugs, we might find that they are already developed the HIV-DR, which is also going to affect our first line regimen when we initiate them on ART. So that's the main reason. As I've highlighted, that it's something that we have started. We've just included it in our guideline. We will be monitoring how what we are seeing. However, we are hoping that it will help us just in case they are positive, they can identify themselves and come to the facilities. Otherwise, the monitoring is not very easy, especially once they have the drugs and they're at home. They are not likely to come back, and there is no way we can get the feedback. However, we are just trusting that seeing yourself having a positive as HIV self-test, it may make you to go to the facility to confirm. In terms of the seroconversions, what we have seen, we do have seroconversions that have happened. What we have seen, the seroconversions, they are not, majority of them, they're coming from the females. And within our CMIS, we, even with the paper base, whenever someone is seroconverting, we have a question that is asking if, because usually they are identified Very few are identified where they are coming for, when they are coming for a refill. Majority, they are identified when they are coming for any other service and they're being tested and we find that they're positive. So for someone who's testing positive, we have a question now that is asking if the client has ever used PrEP. So we do have a lot of seroconversion that we have now, which are linked to ever use PrEP. So the problem, we don't actually know whether the seroconversion happened during the time when the client was using the PrEP, or it happened because we know there are issues of adherence, maybe was not adherent, maybe they've never used the PrEP, they took it from the facility and they've never used the PrEP and they ended up seroconverting. So that's the part that is not so easy. However, we are collecting the information. And from the question, we have gathered that some, they've never used the PrEP, they took it from a facility. Some, they took the PrEP, but they were not adhering. We know for PrEP to be effective, you have to be adhering. So those are the issues. And it's a pity that we discovered them very late. The few that we've discovered that they are coming for their refill as per appointment, and we find that they are positive. They are linked to our healthcare workers having missed diagnosing the acute HIV infection. So as a result, we are emphasizing, we've developed a job aid, which is sitting in facilities, which is helping them to always assess for the acute HIV infection so that they don't initiate clients that are already seroconverting, because they are supposed to defer them if they suspect any acute HIV infection or there was an exposure in the previous 14 days. So they're supposed to defer for 4 weeks and then they can request the clients, to come back, and then they do the test, and if it's negative at the time, then they can initiate. So that's where we are trying to strengthen that component. And we've also included the eligibility assessment, which is looking at the acute HIV, excluding the acute HIV infection in our CMS. It's a mandatory field so that they are forced to ask those questions before they continue initiating the client. So we are hoping that is going to cut down on those that we are picking to be initiated while they were seroconverting. Otherwise, majority of them is the issue of non-adherent, never used the PrEP, but in our records, they took the PrEP out of the facility. So we have those few cases that has happened. So we have tried to put these measures in place, and we hope we are going to learn what other countries are also doing to cut down on the issues, because this is an issue of behavior change as much as we have provided the intervention. Then there was a question on demand creation. I don't know if I still remember what was it about. But if it was linked, demand creation having increased the uptake, I think the uptake that we have seen, it is a combination of all the strategies that we have. The introduction of this being reducing the burden, the pill burden, also the information that we've been flooding them with, it also make them to go to the facility and demand the service. So I think it is just a combination of all what we've been doing as a country to improve the uptake. I think our uptake in general for PrEP, it has improved, especially where we started the demand creation. I will make an example. For this year, we've managed to initiate over 36,000, which is higher than what we've been initiating in the previous year. Our highest ever was 17,000 in the previous year. So we've seen the improvement in the uptake with the demand creation. So we think it is working. And also even with the men, the numbers that we initiated with the demand creation, the introduction of the event-driven PrEP, it has increased. I would say the combination of all these, it has led to the increase.
Okay, thank you so much. There is a question from PNC. Daniel, I don't know what happened to Daniel? Maybe still coming back again, maybe with some other questions.
Okay.
PNC, can you go ahead? Oh,
Since
Daniel, you are there?
Ashka, hello.
Yes,
Hello.
Daniel, go ahead.
Yeah, hello. Yeah, some of the questions that I had, I think you have answered. But there is one regarding to the stigma. How are you dealing with the stigma?
Okay. Thank you so much, Daniel. That one will be covered. PNC, can we go to you? PNC, are you there? Going once? Okay, maybe let's talk about the stigma, Cindy, while we are trying to get more people in our discussion.
Okay, thank you, Bongani. For the stigma, thanks for that question. For the stigma, I think one way of dealing it was removing PrEP from the ART sites, because that's what we did during the demonstration project. We were initiating clients, because these are ARVs in the ART department, and we realized that that was also causing the stigma, and also the dispensing of the ARVs in our dispensary, where there are a lot of other clients who are coming for different services, and they're picking their medication there. And then we then decided to integrate it and to be provided and distributed within the consultation. So the client is being tested, moved to the nurse consultation room, they are being initiated there, and they come out with all the information that they need. The nurse, it's a one-on-one engagement. They come out with the bottle and they go straight home and their appointment. There is no need to pick the ARVs for prevention in the dispensary. That was one way of doing it, and removing it in the ART. In the ART, it's only those that will come as a couple, a serodiscordant couple. The one which is negative, they can pick them up there. So there's no need for them for anyone from coming for any other services to go to the ART for maybe to get the drugs there. And another way we know that the stigma is also attached to the use of the same bottle, the original bottle. We are using TDF and Lamivudine 3TC as for PrEP in the country. So it's the same bottle that we are also using for our first line ART. So there is a stigma that is attached to that. So as a country, based on the feedback that we got from our clients, we have developed some labels. These labels, they are more targeted. Like for the event-driven PrEP, we already have how you take it in the label, so that they can use it around this original bottle. It's an adhesive label, which they can just put on top of the original label. It has all the information about PrEP, the expiry, and also we've included some information on when the client can come back and how to take the PrEP. So for the event-driven PrEP, you'll find a 2+1+1. You'll find the expiry date. You will find your appointment date. So we just put it on top of that original sticker that is there on the bottom. We also have some people that are not at ease or comfortable in carrying this the original bottle. They said the drugs, they cause some rectal. So we've also bought some dispensing bottles, which anyone that is not comfortable using the original bottle can actually empty all the drugs into this new dispensing bottle. And then we have that sticker put on that dispensing bottle, so that we address the issue of the reclaim with the new dispensing bottle. And then the sticker replaces what is written, because the problem is having the same labeling as those that are on ART. So those are the two things that we have done for dealing with the stigma, and we are continuing to engage them on the issue of use of ARVs for prevention. because that's what is needed. People to understand that ARVs are not only for those that are living with HIV. However, with the new technology and science, we have now ventured into the use of ARVs for prevention, as we have used it for the post-exposure prophylaxis. Now it's for the pre-exposure prophylaxis. So those are the things that we've been doing.
Okay, thank you so much. I'm happy that I'm seeing some colleagues from Eswatini answering questions on our chat. Thank you so much, colleagues. Can we go to Kombe? Over to you, Kombe.
Thank you. My name is Mwambe.
Oh,
Ngombe Kabo
apologies.
Ngombe. Okay, thank you. Thank you, Eswatini team, for a very informative presentation. And I would like to acknowledge the efforts that you have made for demand creation. And also, I think I've taken note that the ED-PrEP has improved uptake of PrEP in general. And I want to believe that it's because of that difficult or hard to reach target population. But I'm just wondering, because we are still having the AGYW as well as the discordant women or pregnant and breastfeeding women who are also, I want to believe that they're at very high risk, at elevated risk of acquiring HIV. So I was just interested in finding out how is the uptake and what efforts have you made so that when they remain in the daily PrEP, they also increase the uptake if that's not the case. Thank you.
Okay, thank you so much. Do we still have you, PNC? Hello? Okay, Cindy, go ahead and answer that one. The one from Ngombe.
Okay, thank you. Thank you so much for that question. For the pregnant and lactating women, I will start with those. For those one, I've highlighted in my presentation, for us to improve the uptake, and it has improved a lot. When we introduced the opt-out approach, it has really helped us for PrEP to be provided as part of that opt-out approach that we're using for PMTCT. There is a huge uptake amongst the pregnant and also the lactating. However, I should highlight for the lactating that we are having challenges, especially with in the subsequent visit. We know in PNC, the first 6 weeks, we expect the mother of the child to be coming to the facility for the examination and also for the child welfare part. And then as the child grows, anyone can bring the child in the facility. That's where we start losing the mothers. Most of them, especially those that are working, you will find that they are now sending a helper to take the child to the facility. So that's where we need to come up with some strategies of how do we reach them. Otherwise, during pregnancy, the uptake is very good in the facilities. And recently, we've also introduced it within the labor wards to start sensitizing them about it, so that as they go out, since there is that period, some people, we expect them to go to the facility at 6 weeks, and some people, they start having sex even prior to the 6 weeks. So that's why we are engaging them at the PNC ward about the prevention, so that they take it up, and then when they will have sex before that 6 weeks, where they go to the facility, they can actually visit a facility where they can be tested, and then they can start the PrEP. So that's why we are saying we are now engaging them in the delivery, post-delivery, so that they are aware that in case they will have sex before the 6 weeks, can they go to the nearest facility and they access the PrEP. Otherwise, we know the expectation is to see them at 6 weeks, but it may happen that sex happened early. So for the AGYW, I will say with the oral PrEP, yes, the uptake is there, but we are not happy because, and when we look at our population group, it's young. So majority of our people, they are young. And when we look at the uptake, we are not where we want to be. And especially because when we also look at our incidence rate, it has not improved much. In 2016, we're at 1.64. In 2021, we're at 1.63. So that tells us that not much has happened, despite the DREAMS project that is moving around in the country through the mobile outreach and providing the service. So for these ones, we know as we're engaging them that they said taking the drug every day, it's not for them. So we are looking at the expansion of the products. So we believe that once the Kevlar is available, we are likely to see a good uptake amongst that group, because as I've highlighted that we are currently piloting the ring. We are also seeing that the uptake is not good among them. The group that is taking up the ring is the 25 years plus. So the below 18 to 24, they are not. So the oral PrEP and the ring is not working for them. We can actually tell from where we're standing now. So the Kevlar, we think, and that's what they've indicated, that they are likely to take the injectable than these two. However, we are continuing to provide and to make sure that we still emphasize on the other prevention services so that they are protected. And we know that they are very sexually active. That's why we are seeing that incidence rate. So it is really a challenge for the adolescent girls.
Okay, Gombe, you have a follow-up question?
Yes, because I was the reason why I was raising that one, especially for the AGUW, I don't know, but I want to believe that maybe it must be the same throughout the countries, especially in the southern region, because they really don't like taking a tablet. They even have stigmatized it to say they don't want to take a tablet every day to avoid taking a tablet for life. And I was wondering why, when the WHO released the event-driven PrEP, why didn't they consider the AGYW as well? I don't know, maybe I'm preempting something, but I was thinking that they are also part of the people that could have been considered. Thank you.
Okay, go on.
Okay, the reason they're not, okay, females in general, they are not to benefit on the event-driven PrEP. It was scientifically proven that it worked amongst the men. We remember that the trials, they included the MSM, but then it was extrapolated that anyone that is born male, they can benefit from the event-driven PrEP. It did not work for the females. I think it's because of the anatomical structure. Otherwise, it is proven that it's not working unless, as they continue with the trials, they can maybe identify something that maybe it's working, but for now it is not working for males. So that's where we're also struggling. The females, especially the AGYW, they are always demanding the event-driven PrEP because they've heard about it, saying that why aren't we not given the event-driven PrEP? So it is important to clarify that it has been proven to work for those that are born male than the females. So that one is a given. That's why it has been recommended for males based on the scientific evidence that it's working for them. I think what is happening with the anatomical structure for both these two sexes. That one, I think it's something that they also need to further explore. Otherwise, it's only working for men, born male.
Okay, thank you so much, Cindy. And again, colleagues, let's take note of the questions that are there on the chat. Especially there's one from the Mozambique team, a long one, but we need to look at that one. And maybe because of time, I think colleagues now, it's time for us to maybe at least look at or make the countries that are here maybe reflect on if these presentations and this discussion from Eswatini has maybe helped them in a way. We have Mozambique here, we have, I think it's South Sudan, We also have Botswana, if I'm not mistaken. Maybe can we go to South Sudan? Just a reflection of what they have learned, and then maybe things that they think they can share with Eswatini, or we can share with them from Eswatini to see a way forward. Anyone from South Sudan? Okay. Anyone from Mozambique? Okay,
Okay.
there's James. James?
Yeah,
Oh, it's Daniel.
I better speak in Dutch. Daniel.
Okay.
Yeah. Bom, ok. A minha colega também levantou a mão, acho que pode falar, a Isabel, né?
Oi, Daniel. Yeah. Pode avançar se tem alguma coisa que depois posso acrescentar, se não for muito tempo, se nos for
Ok,
permitido.
ok, tá bom. Eu acho que foi uma excelente apresentação. Partilharam várias experiências. Muitas coisas são coincidentes com as coisas que nós estamos a fazer. Claro que a Eswatini está bastante avançada e também em termos de cobertura de unidades sanitárias, espaço onde está a fazer e intervenções. Nós ainda temos baixas coberturas de oferta da PrEP ao nível das unidades sanitárias e também há várias abordagens que têm a ver com a disponibilização em todas as portas que tem estado a fazer e, pelo que percebi, mesmo para os pacientes internados. Nós, a oferta da PrEP sob demanda é uma intervenção que iniciou há pouco tempo, acho que um pouco tempo depois em relação a vocês, ainda precisa de uma questão de avaliação. Temos o desafio da estratégia de comunicação, pelo que eu percebi, vocês já têm isso disponível. Seria interessante também partilharem conosco esse instrumento, porque nós estamos em processo de elaboração e melhoria deste instrumento de estratégia de comunicação para a PrEP. Há uma pergunta, acho que a Isabel vai acabar fazendo, mesmo que tenha a ver com a questão das populações-chave nos registros. Como é que fazem para as pessoas que têm sobreposição de grupos, né? Que seja, vamos supor, PID, trabalhador de sexo ou HSH, como é que estão a fazer? Não sei se a Isabel tem algo a acrescentar.
Yeah, obrigado, Daniel. Bom, só iria mesmo acrescentar em relação a como é que tem feito esse registro. Gostaríamos de aprender um pouco mais e estão a fazer e também podemos partilhar a experiência de Moçambique. E também não vi aqui em algum momento a questão em relação à seroconversão, se já existe dados disponíveis sobre a seroconversão entre os usuários que estão a fazer a PrEP sob demanda. E também gostaria de perceber o que pudessem partilhar a experiência. Não ficou muito claro como é que tem feito o tratamento em relação à farmácia. Percebi que dão medicamentos de acordo com a sobra que o cliente tem na consulta em que ele vai participar. Então, como é que a farmácia está a trabalhar quanto a isso? Os frascos estão abertos e entregam um número de comprimidos. Isso também é uma coisa que nós gostaríamos de entender, uma vez que o Moçambique apenas dá os frascos selados para que o utente faça a gestão. Gostei muito da experiência que partilharam em relação à troca das capas do medicamento, uma vez que eles são praticamente os mesmos com os ARVs das pessoas que estão em tratamento. E acho que essa é uma boa experiência. Depois poderem partilhar as imagens também seria interessante, mas Moçambique também está na linha dos países que já pediu a troca daquilo que são os frascos da oferta da PrEP. E também em relação à questão das consultas, daqueles que estão a fazer PrEP sob demanda, que voltam às consultas com mais de 20 comprimidos. Qual é o tratamento Eu dou mais 10, dou mais 30? Como é que isto efetivamente funciona? E obrigado, parabéns pela experiência e por partilharem isto conosco. Obrigada.
Thank you so much, Team Mozambique, I think, yeah. There is James. You can go ahead.
Yes, hello.
James, yeah, we are with you.
I hope you are hearing me very well.
Yes.
Though I joined the meeting late, but almost 20 minutes, but I actually received a good number of informations and experiences from what the team has presented. Actually, I'm one of the champions of South Sudan, and also I work at Juba Teaching Hospital, which is the main hospital uh, in South Sudan, Juba capital. I did not get a good number of information, but what I pick actually is a very good experience. Just through this presentation, actually, we are able to learn a lot of information and share experiences with our neighboring countries. But I have no any presentation to give. I have my team members. If they are around, they will also, if there is any presentation, they will give the presentation. But I appreciate the presentation given actually. Thank you very much.
Okay, thank you very much, James. I think it's not a presentation as such. It's more of your takeaways, what you've learned from this one, anything that you want the team here to help you with. But thank you so much for what you've observed and your comments. Anyone else from South
Yes.
Sudan?
Yes. Good afternoon. Sorry, I came in. I was trying to connect, but I think I faced some challenges with the technology. However, I would just go really straight to the key takeaways from this presentation. My name is Wilson Moga. I'm from South Sudan. Just giving a bit of a background of how far we have come with PrEP. We started the PrEP implementation last year, and really there are a lot of things that we learned from this presentation. And I want to just really give a big thank you to the team, Eswatini team, for really making this presentation detailed and comprehensive. And I think my team and the other people who are around also, they have really picked some key points from this. We as a country, we have included event-driven PrEP in our program, in our national guideline. However, we have not really expanded it to bring in all those aspects of monitoring and even expanding it to other populations. So this is really a very good presentation for us. The other thing we have also not done is really updating our national guidelines, because we just started the PrEP programming last year. So one of the key takeaway for us is to really look into our national guideline for PrEP and try to update to the recent WHO recommendations, so that we'll be able to provide the event-driven PrEP. Because apparently we are just thinking that event-driven PrEP is only given for MSM. So this is something new for us, and we will take it up and for further discussions and see how best we can integrate it into our national PrEP guideline. The other key takeaway that we can really pick up from this, because we know very well there are issues to do with pill burden among the PrEP users. So really the issue of switching regimens, from event-driven to daily use of PrEP is also one of the areas that we will have to critically look at as a country and see how best we can adopt that to be able to really improve our programming, since we have just started our programming. The other key takeaway that we really wanted to make it also clear for everyone is that currently our PrEP monitoring has been done on paper-based. So we have also seen how best Eswatini has been able to integrate that into the national management information system. So this, for us as a country, we would really like to adopt this and try to find a way to integrate PrEP into our national management information system in order for us to also really utilize information well for programming purposes. These are really some few of the takeaways that I will be able to put forward, but there are really a lot that we have learned, and we would wish that we would be able to share more, maybe this presentation or maybe some documents, especially about the behavior change strategies. If we could also learn more from that, I think it will also help us as a country to see how best it has really helped the programming. In conclusion, I just want to thank the Eswatini team for the excellent presentation, and also the SSLN for really inviting us for this wonderful presentation. And we really look forward to collaborate further and discuss maybe bilaterally to see how best we can be helped on other key areas as a country. Thank you very much.
Thank you so much, Team South Sudan. Anyone from Botswana?
Thank you, Team Eswatini. I'm hoping that my team members will add to what I've just taken as the key takeouts. I'm just appreciating the explanation or the expansion of the event-driven PrEP, which I think I've heard about it, but I didn't get it right the first time I heard about it. The other thing that I've also taken as a takeaway is the taking PrEP out of the IDCCs, because that's one of the things that Botswana is trying to embark on, because our PrEP has been like given at our IDCCs, and it that stigma has like made our low uptake of PrEP in general. And the other important thing that I've also taken out is the importance of demand creation, where I'm realizing that we really have some things that are going in Botswana, but we are not taking use of. Like in Botswana, we have issues like we have activities like men in Botswana it's called Pitso Aborre, where it's just men having in-depth dialogues, and we have never tapped on them. So I'm seeing that we can have those being utilized to increase demand for PrEP by more especially the men. Thank you.
Thank you so much, Botswana. You can go ahead.
Okay. Thank you, Kabo, for sharing. In addition to what Kabo has already said, one of the things that I want to share with the team is that as Botswana, we are happy to tell you that we will be launching our new HIV/AIDS guidelines on the 26th of September. And one of the gaps that we have identified in the country, like she has already said, is demand creation for PrEP and the low PrEP uptake. In our new guideline, we have adopted the two methods, the event-driven PrEP and the injectable PrEP, which we think will also help us with the uptake of PrEP in our country. And to say, we really appreciate this presentation by Eswatini, because it has come at a right time where Botswana is starting to officially provide event-driven PrEP in our country. Initially, we have been providing it to selected cases because it was not adopted in our guidelines. So from now onwards, after launching the guidelines, it will be provided in the country. And some of the challenges that Eswatini has shared, I think they will also help us as we plan on the implementation of the injectables and the event-driven PrEP. And also, like Kaba has said, Botswana has been offering PrEP only in IDCC facilities or ART facilities, and we are looking into expanding PrEP to other service points within our facilities. And I think this is one of the things that we will learn from Eswatini. And may we kindly ask the Eswatini team to share their presentation and also to share other documents, supporting documents that they are using. I've also realized that in our country, we only have one guideline, like the, the integrated HIV clinical care guideline that has embedded PrEP in it. But I've realized that for Eswatini, they actually have two separate guidelines. They have a specific guideline for PrEP. We also like the team to share that with us. Maybe it's something that we can also embark with, because we have realized that having PrEP embedded in the master guideline, usually we just have a summary of the procedures that to be done, and they are not really expanded. Maybe having a specific guideline will also help the country. So, and also one of the things that I've realized that we are missing on is having a line list of clients on PrEP. We do have registered that we use to follow up clients who are on ARV treatment, but we have not been following up on clients who are on PrEP, and maybe that is why we have been missing clients not coming for follow-ups. I think this is one of the things that we learned from Eswatini that we will take up in our country, and maybe they will help us with the follow-up or retention in PrEP. I think I've said a lot, and one of lastly, the scenarios that Eswatini shared, I think they also helped us because we have envisioning the ED-PrEP from one scenario of taking it once after one exposure. I did not have that in mind, that there may be different scenarios to ED-PrEP. So I think these scenarios also have opened my mind when it comes to ED-PrEP. Thank you so much, Team Eswatini and the rest of SSLN team.
Thank you so much, Pearl. Maleboha.
Thank you so much. This is in addition to what both Pearl and Gombe has spoken to about lessons learned from Botswana. So I had wanted to highlight on the issue of stigma related to especially accessing PrEP from IDCC, that is the treatment part of HIV. So as already alluded to, you'd realize that efforts have already been done to try and decentralize offering of PrEP from IDCC to multiple service delivery points. And currently, we have identified a few facilities where we have trained nurse prescribers and dispensers who are as well midwives and are currently offering PrEP from SRH department. And mainly here we are targeting pregnant and breastfeeding women, including all the women that are accessing contraceptives from those service delivery points. And as it is, or as a result, we are seeing numbers coming through from people being offered and initiated PrEP from those multiple service delivery points, being SRH and the general OPD. And mainly when you look at the data, it's mostly women who are accessing PrEP from those multiple service delivery points, not just limited to SRH, but OPD and the HTS room as well. So this is something that I'm thinking and hoping that it will improve PrEP uptake in our program in Botswana. Thank you so much.
Thank you so much, Team Botswana. Anyone from Zimbabwe? The last one. Anyone from Zimbabwe? Okay. I don't know from the Eswatini team. Cindy, do you have your summary on what they have said and what the documents they think they need the team Eswatini to share?
Okay, thank you, Bongane, and thank you to all colleagues who have really shared your key takeaways and also shared what you are doing. I think we've also learned in the in the presentation or in the discussions that we've had. Even those questions that we're asking, those are some of the things that we are also looking at. So they are also helping us as a country to also look at other issues and how you are also dealing with the challenges, because most of the challenges are the same across all countries. So we really appreciate all the question and also the input and what you are doing in your respective countries. We appreciate the sharing of information. In terms of sharing the documents, yes, I will share with the coordinators of this learning and network so that they can share with you. I think even the presentation they can share. I'll also share, we can share the labels, maybe it's something that you can consider, especially because of the issues of this same bottle that is used for PrEP and also for ART. Maybe it's something that you can also consider in trying to address some of the issues. And they already developed IEC material that we're usually distributing. I can share a copy with the team and then they can share with you. There were the guideline, our PrEP guidelines, they're a draft. We just want to finalize the piece on the Kebla, but then once we finalize, we'll share with you, I promise. So after the training that will be happening in Zimbabwe, in Zambia, I think it's on the week of the 10th, we'll come back with what, because we are looking for more information that we might have missed. So we're going to include it and then we're going to share with SSLN so that it can be shared with you. And we'll really appreciate if you can also share any document that we may have, but I'm promising that we're going to share the documents, the communication strategy, the IEC material that we're using, the guidelines, once we have finalized them, which we hope it will happen somewhere in October because of this training, we're going to share that copy. Otherwise, like Botswana is highlighted, we do have the integrated HIV management. That one, they have been finalized. However, it's also summarized. The PrEP version is summarized there. So we really have the comprehensive part in the PrEP guidelines. So I think what is key is for us to share the PrEP one, which once we finalize, we are going to share with the team. There was a question on the key POPs. I think it was South Sudan, if I'm not mistaken. Yes, we are able to capture our key population, the MSM sex workers, with transgender, because we have a full program that is targeting them through mobile units and also through our outreach services. So we do have a database. So we're able, if we want data, to analyze that specific data. We are struggling when they come to the facility. However, it's just that they are not disclosing. However, our CMIS is able to capture them if they are able to disclose. So we usually miss them because of that. However, we're able to use also the database from the key population program to track them within the public service or CMIS if they've come for any other facilities, and it gives us a better picture of our data in the country. In regards to the pharmacy, it's one area that I've highlighted that we are yet to venture in. We are looking at also distributing through that. We are at the verge of planning how we can do it, especially because we also need to track the data, because there will be a refilling. So how are we tracking the data and how do we distribute them? How do we distribute the drugs through the pharmacy outlet? Since that is private, they have to be linked to a facility, but it's something that we are working on. Maybe in future experience sharing, we might share if we've already established and structured it, how we are doing it, but it's something that we are considering as a DSD model for PrEP. I think I've answered, or the issue of the bottles, I think I've highlighted that you have to ask whenever these males are coming for a refill, how many do they still have? If you feel they still have adequate drugs with them, there's no need to dispense, because the way they've used maybe the first bottle, it will tell you how often were they exposing themselves to sex and there was a need to take the drug. You may find that the bottle is almost full, maybe they had they just had one event, so there is no need to give another full bottle when they still have maybe about 26 of the drugs sitting at home. And if that tells you that the frequency of the sex is not happening as much, so you also have to use the discrepancy, your discretion, for you to distribute more drugs. Otherwise, they'll find themselves sitting with a lot of drugs at home, which might expire. They might use it once they have expired, or they start distributing to their friends without testing. So those are some of the things that we have to guard against. So that's what I can say. Otherwise, thank you so much to SSNL for giving us the opportunity as Eswatini to share what we are doing on PrEP, and also to be part of this a network, and also learn what other countries are doing. We have really learned a lot from the discussions that we've had. Thank you so much for the opportunity.
Thank you so much, Cindy. And for me as the chair, maybe let me take this time to thank everyone that attended. Thank again. We appreciate what the SSLN is doing. Thank